Is everybody able to see my screen?
Yes.
Okay,
Yes.
great. Okay, so these are my disclosures. By way of introduction, I think it's useful to look back at clinical PET-CT. When it came on the scene, it was viewed as a disruptive technology. It blended molecular imaging with anatomic imaging, and it was a bit of a painful transition, but it led to amazing results in cancer imaging. And I think we're now witnessing a similar marriage of PET-CT molecular imaging with interventional radiology. And it's similarly presenting challenges and opportunities. At present, there are very few molecular imagers who perform interventional procedures and few interventionalists that are molecular imagers. So I structured this talk around myths and misconceptions in the field of PET-CT intervention. And we'll use that to take you through what we've learned, including a big surprise, and then finish up with what's next. Why do we think there are myths and misconceptions? Well, it's really through conversations with our colleagues here and elsewhere, people that visit us in the Amigo, conversations at meetings, and even comments from peer review when we submit manuscripts for publication. In fact, we prepared a primer with one of our recent publications that defined ablation terms, ablation concepts, and concepts unique to PET-CT guided ablation to be helpful for the reviewers. And we suggested that it could even be considered as an online supplement, which they decided to include with that particular publication. So myth number one: tumors may not remain visible on FDG PET throughout a long procedure because of radioactive decay. Well, F18, the radionuclide for FDG, does have a half-life of about 2 hours. So if you inject the tracer 1 hour before the procedure, that means 1 hour into the procedure, you have about 50% of the activity that you started with. And 3 hours into the procedure, maybe about 20% of the activity. But it turns out PET can still image tumors with that amount of activity on board. And it's important to realize that tumor conspicuity is not just about the absolute activity in the tumor, but it has a lot to do with tumor to background ratio of activity. So many diagnostic PET studies have shown over the years that if you obtain a PET scan at 1 hour after a tracer administration and compare it to scans obtained at 2 or even 3 hours after tracer administration, we often pick up additional tumors on the later time point scans. And we've actually observed this in our procedures, that tumors that we're targeting sometimes become more visible later in the procedure. So we really don't have a problem with ability to visualize tumors throughout a long procedure. And this visibility of tumors on PET is helpful in many regards. Some tumors are invisible on CT, such as this recurrent mesothelioma in the chest wall. It was FDG avid, which allowed us to target it for cryoablation. This recurrent lung cancer was completely obscured on CT by surrounding radiation pneumonitis, but we were able to, on PET-CT, target it for biopsy and ablation. This small tumor that was a recurrence from adrenocortical carcinoma between the inferior vena cava and the crus of the diaphragm was targeted for both biopsy and ablation. And even the metallic artifacts that might obscure the nodule on CT are not a problem for PET, and allows us to see the relationship of the tumor to the probes. And of course, sometimes we pick up unexpected tumors that we didn't know were present. In this case, there on the bottom 2 rows, there were known metastases to the liver or adjacent to the liver. But on the top row, we picked up additional unsuspected tumor, which we also targeted during that procedure to improve the outcome. This patient had lung metastases that we ablated. Yes, they were visible on CT, but when we do the procedure, we distorted the anatomy by creating a pneumothorax so that we could displace the nodule away from the mediastinum where the phrenic nerve was located. And things happen during lung ablations. We get hemorrhage that can obscure the nodule, atelectasis that can obscure it and change the anatomy. And the ablation itself causes consolidation that obscures the nodule. But no matter what happens, we can obtain a PET-CT at that time point in the scan and still see the nodule where it truly is located. So we think of FDG PET as our beacon in the fog during these interventional procedures in PET-CT. Myth number 2, PET-CT procedures are too long to be practical. Well, one thing we noticed early on is that we can acquire PET scans as short as 20 seconds. Traditionally, diagnostic PET acquisitions per bed position are at least 1 minute long, sometimes 3 minutes long. In this case, we looked at 20-second reconstructions all the way up to 3-minute reconstructions of PET. And yes, the 3-minute image is prettier, it's smoother, but on the 20-second PET, even though it's a little bit noisy, we can still get the same spatial localization of the tumor, and we still see the shape and size of the tumor. So that meant that we could do very short single bed position PET CT scans with a PET acquisition of 15 to 20 seconds and get the entire PET CT in a single breath hold as short as 35 seconds. That's pretty impressive and pretty fast. And we retrospectively compared the duration of our PET CT guided procedures to comparable CT guided procedures. And what we found was, if you look at this graph on the left, the blue box and whisker plot is the duration of our PET CT guided procedures. The red box and whisker plots are the CT guided procedures by different operators. And the duration was not that different. On average, PET CT guided procedures were about 22 to 28 minutes longer, which is very reasonable. And the radiation dose to the patients was only minimally larger. So we think PET CT is certainly fast enough for interventional oncology. And additionally, we can adjunctively use ultrasound or CT fluoroscopy to expedite the procedure. And there are more strategies that I'll get to towards the end of the talk. Myth number 3, radiation dose to the operators is too high. Well, it is true that wearing our lead aprons is not helpful. The 511 keV photons from positron decay penetrate our lead aprons, and so it doesn't help to wear lead aprons. But many studies have looked at operator dose, and it's actually very well within acceptable standards and not that much different than other interventional radiology procedures that we perform. But there are things to remember. One is that we can minimize our dose by using the least amount of activity necessary that we inject into the patient. We also minimize our time in close proximity to the patient. So when we're not actively manipulating devices, we can step back. And we're even using a custom rolling lead shield that we had made for the Amigo. This has 1-inch thick lead. It blocks almost all of, like 95+% of the 511 keV photons. But the real question is, is it really even worth the effort to use this, because the operator dose is not that great? Myth number 4, tumor radiotracer activity is attenuated or dissipated by thermal ablation. This is a big one. And when people think at first blush, we give FDG at the beginning of the procedure, the tumor takes up the activity, then we ablate it. The tumor's dead. Why would it be hot on PET? Well, let's look at that. So if you have a tumor in the liver, you give FDG, the tumor is hot, there's FDG trapped in the tumor cells, and then you do an ablation. You either freeze it or you heat it. Well, the temperatures that we cause with thermal ablation, whether we heat it or freeze it, do not change the rate of radioactive decay of our isotopes. And the thermal ablation process actually isolates that part of the liver. The ablation zone becomes devascularized. It's no longer perfused by blood, so it traps everything in the ablation zone. There's no place for the radiopharmaceutical to go. So the tracer decays at the rate it would even if you didn't do ablation, and the tumor remains visible after ablation for the several hours following ablation. We documented this in a study in which we compared our PET CT guided radiofrequency and cryoablation procedures and compared them with PET CT guided biopsies. We looked at the SUV of the tumors before, at the beginning of the procedure, and compared it to the SUV of the tumors at the end of the procedure. And there was no significant difference between the ablation group and the biopsy group. In fact, the SUVs increased at the end of the procedure, as you would expect, based on dual time point diagnostic PET studies in the past. The tumor to background activity actually improves as you get later into the procedure. So this persistent tumor visibility, even after ablation, has implications for us in interventional PET. One is that we can certainly use PET for initial targeting of tumors. And then no matter what happens during the procedure, We can retarget the tumor, even if we've lost visibility of the tumor on our CT scan. And we can now consider how to use PET to assess the tumor ablation results. And we certainly cannot expect to see the radioactivity to disappear because of ablation. That's not going to work. So we'll have to find another strategy. So before we get into that, when we assess ablation results, the most important thing we're looking for is the adequacy of our ablation margin. That is, how far beyond the tumor we've ablated. And this is analogous to the surgical margin. When the surgeons resect a tumor, the specimen goes to pathology, they slice it, and they look under a microscope to see how close the tumor approaches the resection margin. If it is at the margin, that's a bad indicator the patient is going to have a recurrence. If it's a wide margin, very little chance of recurrence. It's the same thing for our ablation procedures. We want to achieve an ablation margin that's at least 5 to 10 millimeters in thickness. And not only that, the minimum margin is critical. In other words, you can have a thick margin around most of the tumor, but if in one spot you have a zero margin, that's the weak link in the chain, and that's where your recurrence is going to occur. So we need to be able to assess the entire margin and find the minimum margin and be able to measure it. So schematically, if you look at it, this blue tumor we're going to ablate. The ablation zone is this egg-shaped structure surrounding the tumor. So the ablation zone or volume includes the blue tumor and the yellow margin, which is how far beyond the tumor we've ablated. And it looks like a thick margin all the way around, but on the top right, we can see where the minimum margin is located. And if it's less than 5 millimeters, we consider that inadequate. Now, why do we need the margin? Well, it's because there can be microscopic extensions of tumor or small satellite nodules that measure 3 or 4 millimeters in size or 1 or 2 millimeters in size that we cannot resolve on our conventional imaging modalities. And if we don't include this in our margin, we're going to have a recurrence. That's why we need the margin. Myth number 5, the ablation margin can be reliably assessed on contrast-enhanced CT or ultrasound. Well, this is how we have traditionally assessed our ablation results while the patient is still on the table because we didn't have anything else. But this is what we see. When we give contrast at the end of the ablation, the liver is perfused, but the ablation zone is no longer perfused by blood, it's coagulated. And so the white arrows show the hypoenhancing ablation zone. But notice that we cannot define the tumor within the ablation zone, it's obscured. And this is just another example. The ablation zone is beautifully demonstrated on contrast CT, but the tumor is not visible within the ablation zone, so we cannot directly measure the margin. And our metallic ablation device is contributing to the problem because of its metallic artifacts. But we like to know how adequate our margin is at this point, because if we need to do an overlap, we can then just reposition the probe very easily. Contrast-enhanced ultrasound has the same problem. The ablation zone is non-perfused. We cannot define the tumor within the ablation zone. With both of these techniques, if there is hypervascular, bulky tumor outside the ablation zone that we didn't ablate, we can pick it up with these techniques, but we cannot assess the ablation margin. Interestingly, this paper just came out recently, titled, "Can Accurate Evaluation of the Treatment Success After Radiofrequency Ablation of Liver Tumors Be Achieved by Visual Inspection Alone? Results of a Blinded Assessment with 38 Interventional Oncologists." What did they find? 44% of the time, the radiologists misjudged the adequacy of the ablation results. And having more expertise wasn't helpful. It's a limitation of the technological approach. So what did they conclude? Conventional side-by-side evaluation of treatment success after RFA of liver tumors by the juxtaposition of pre- and post-interventional CT scans is very difficult for experienced radiologists. The implementation of advanced processing techniques such as rigid, non-rigid image fusion with the assessment of the periablational margin is thus likely needed in order to decrease errors and objectively evaluate technical success and predict technique efficacy of liver RFA. So we've established that we can nicely define the ablation zone with our contrast enhanced modalities. The problem is that we don't usually see the tumor within the ablation zone. So you may have a nice large ablation zone, but if the tumor is eccentrically located, you may have an inadequate minimum margin. Hence all the interest in image fusion technologies and the countless publications and projects that have used image fusion to try to address both the targeting problem and the ablation margin assessment problem. But what are the challenges? Well, almost all of these technologies require a retrospective data set to demonstrate the tumor after ablation. But between the retrospective data set, that might be an MRI obtained 2 weeks ago, or it might be a contrast enhanced CT scan obtained with the patient on the procedure table at the beginning of the procedure, but then you're fusing it to a CT scan obtained at the end of the ablation procedure. So it's still a retrospective data set. And there can be changes in the body or organ position that occur, changes in organ shape, respiratory variation is a problem, distortion caused by the insertion of needles and ablation devices is a problem, and we cause gross anatomic distortions with our other maneuvers like artificial ascites, artificial pneumothorax, pneumoperitoneum, and so on. And then things like atelectasis and hemorrhage distort the anatomy and obscure the anatomy. And there's substantial tissue contraction that is caused by thermal ablation is another thing that is very difficult to address with retrospective image fusion. So can PET-CT help? Well, not surprisingly, the initial concepts of using PET to address or assess ablation results centered on imaging residual unablated tumor. So for example, in a mouse model, radioactive water perfusion was used to identify residual unablated tumor. In clinical trials, a split dose FDG technique has been advocated where a small FDG dose is used for targeting of the tumor, and then a larger dose is administered after ablation to look for residual unablated tumor. All of these methods are looking for residual unablated tumor. So myth number 6, the best way to assess tumor ablation results during PET-CT guided procedures is injecting tracer immediately after ablation to image or measure residual viable tumor. Well, the split dose technique was evaluated in these studies from one center. And in the first study, they looked at 29 tumors. And at the end of the procedure, they gave additional FDG, waited 30 minutes, and it imaged. And in 28 of those tumors, they had no detectable residual tumor, but 2 of them recurred anyway. And the one that did show residual uptake was reablated. Now, the median follow-up was 5 months. The longest follow-up was 8.5 months. So it begs the question, were there additional cases with local tumor recurrence? They subsequently tried a more quantitative approach in 2016, where they injected FDG after the ablation and did a large ROI to include the entire ablation zone. And they compared the maximum pixel activity concentration of FDG within the entire ablation zone, including the adjacent tissues, relative to the average FDG activity concentration in normal liver. And they indicated that they were 100% accurate in predicting outcome with this approach. But in a subsequent paper, the same group found that the SUV ratio alone did not prove statistically significant in predicting outcome. So what is going on here? Well, I think they're running up against the spatial resolution limitations of PET. And this actually was early on in the diagnostic PET experience. Many studies were done of patients with melanoma or breast cancer to evaluate regional lymph nodes with PET. And the hope was that maybe PET would be so accurate that we could avoid sentinel node biopsies or regional node dissections. But in fact, PET was not able to pick up foci of tumor as small as 2 or 3 millimeters in size, let alone microscopic foci of tumors. So it really didn't pan out as a way to obviate the need for these lymph node dissections. And the same problem is illustrated here, where we can't really reliably pick up very tiny foci of unablated residual tumor. And of course, we're not getting any information about the ablation margin with these approaches. So if you look at it schematically, let's say we do an ablation and we get an ablation zone that covers the tumor like this. Well, you may have this 10 by 30 millimeter blob of unablated tumor. If you inject FDG at the end of the procedure, yes, you're going to be able to pick this up. That's great. But what if you get an ablation zone like this, and you're left with maybe 1 or 2 foci of tumor that measure 1 to 3 millimeters in size? PET is not going to reliably pick this up. It's really below the detection limits of PET. So suppose you get an ablation zone that covers the entire macroscopic tumor. Well, if you look more closely, perhaps you have a less than 1 millimeter margin over here, a 2 to 3 millimeter margin over here. You're still at high risk for local recurrence. And why is that? Well, because we talked about the satellite tumors and microscopic extensions of tumor. This is why we need a margin, so that we include these things that we cannot detect on our imaging in the ablation zone to reduce the risk of local recurrence. Now, there's all types of research going on nanoparticle imaging and things like Raman spectroscopy that can potentially even pick up a single malignant cell. These are technologies that may potentially be very effective for mucosal imaging or imaging within a few millimeters of a mucosal surface. There is some indication that it may be able to detect tumors even deeper than that at some point. But until these technologies are realized and are able to provide whole body imaging where we can detect sub-millimeter foci of tumor deep in the body or even microscopic foci of tumor, until that happens in the ablation world, we're going to be focused on achieving an ablation margin. That's what we have to do. So can PET-CT help us assess the margin? Well, we're going to capitalize on the fact that the tumor remains hot on FDG PET after thermal ablation. And that gives us 3 PET-CT options for assessing the margin. The first one is, if we do an FDG PET-CT guided cryoablation, the tumor will be hot at the end of the cryo. The ice ball is beautifully visualized on CT, sharply marginated. And we're going to do breath hold PET-CT for excellent co-registration of the 2 data sets. We recently published our results with these PET-CT techniques, and this is what it looks like. At the maximum ice ball formation, we do a PET-CT. The tumor is still FDG avid on the left. The CT shows the ice ball on the middle image. And on the fused PET-CT, the overlay allows us to measure the margin indicated by the asterisk all the way around the tumor on every slice. In this case, the minimum margin was 5.5 millimeters, and there was no local recurrence. This patient underwent a palliative cytoreductive ablation. It was a multifocal recurrent mesothelioma. This was the dominant mass. We cryoablated it. The tumor is FDG avid on the top left. On the top right, you see the CT depiction of the ice ball. The fused PET-CT image C shows that tumor extends to the edge of the ice ball. And of course, that was one of the sites of local progression afterwards. And of course, we can scroll through the data sets, the PET-CT data sets, and assess the margin on every single slice, which will help us find the minimum margin. We can also use multiplanar reconstructions. And no matter what type of anatomical distortions we cause, like in this case, we created a large pneumothorax on purpose so that we would avoid going through the lung when we put our probes into the liver dome. And then we could see the ice ball on our fused PET-CT at the end of the procedure. And we were able to measure the adequacy of the margin all the way around this irregular tumor on all slices through the tumor. A second approach is after microwave ablation, doing PET contrast enhanced CT. So we're going to use iodinated contrast. The tumor will be hot after ablation. The contrast enhanced CT shows the non-enhancing ablation zone. And we're going to do our breath hold PET-CT. And this is what it looks like. The tumor is hot on the left. The non-enhancing ablation zone is depicted on contrast enhanced CT as part of the PET-CT, and the fused display on the right allows us to measure the margin all the way around. In this case, the minimum margin was 6.5 millimeters, and there was no local recurrence at 27 months. Another case, the tumor was still avid after microwave ablation. We see the ablation zone on contrast CT, but notice on the fused PET-CT, the tumor extends all the way to the edge of the ablation zone where the white arrow is. And of course, that was the site of local recurrence. So we looked at our overall results, and one of the nice things that we found was that with PET-CT, we're almost always able to assess the margin circumferentially on every slice through the tumor in 95 to 96% of cases. That's compared to MRI obtained after the procedure, where it was more like 60% of the time that we were able to fully assess the margin on every slice through the tumor. And when we used 5 millimeters as our ablation margin, minimum margin threshold, the PET-CT assessment nicely stratified the tumors that were likely to recur from those that were not likely to recur. 10% of tumors with an adequate margin on intraprocedural PET-CT progressed, whereas 41% without an adequate margin progressed. The third approach is to do perfusion PET after the PET-CT guided ablation. So again, the tumor will be hot after ablation. The ablation zone is devascularized. It's coagulated by microwave ablation. And so we're now going to do a perfusion PET to bring up activity in the normal unablated liver. And it doesn't require an additional uptake time. We simply inject the perfusion tracer and immediately scan. We first reported this in 2018 using N13 ammonia as our perfusion tracer. N13 ammonia is a well-known cardiac perfusion tracer agent used to assess myocardial perfusion, but notice it also perfuses the liver and anywhere else that blood goes. And so the concept looks like this. We have a tumor in, for example, the liver. We give FDG, and it localizes intensely within the tumor. There's mild activity throughout the liver. And now we do an ablation. And if the ablation zone looks like this, and if we now obtain a PET-CT scan after ablation, it's going to look pretty similar because the ablation does not dissipate the FDG activity. It doesn't change the rate of decay. But the ablation zone is devascularized. There's no longer blood perfusion into the ablation zone. So if we give a perfusion tracer, that's going to bring up the background liver activity and leave this photopenic ablation margin. So we have pre-procedural activity trapped in the tumor. We have pre-procedural mild activity plus the perfusion activity in the background normal unablated liver, and that leaves this photopenic ablation margin that we can now assess. And what does that look like? So on the top left, we've targeted an FDG-avid tumor. We've done microwave ablation. On the top right, you see the perfusion PET. There's residual trapped FDG from the pre-procedural dose in the tumor. And there is perfusion activity in the normal unablated liver indicated by the asterisk. But the photopenic margin surrounds the entire tumor, and it looks pretty generous. And when you compare it to the post-contrast enhanced MRI, it also provides a very comparable assessment of the ablation margin. And another example, microwave ablation of an FDG-avid liver tumor. On the CT scan with contrast on the top right, we cannot see the tumor where it's obscured by gas. But on the bottom left, the perfusion PET nicely shows the generous photopenic margin surrounding the entire tumor. Notice in this case on the MRI, bottom right, the tumor is partially obscured within the ablation zone and we can't fully assess the margin. Myth number 7, ablation-induced hyperemia will confound the PET-CT assessment of the ablation margin. Well, we do often see increased blood flow surrounding the ablation zone immediately after ablation. And actually this perfusion PET that I just showed you illustrates that. You can see there's increased flow around the ablation zone. But it doesn't penetrate into the ablation zone because it's coagulated, and it doesn't interfere with our assessment of the ablation margin. In this case, we did a microwave ablation of a tumor, and on the top right, the perfusion PET is superimposed on the CT image. You can see the U-shaped ablation margin surrounding the tumor posteriorly, but anteriorly, normal liver activity blends in with the FDG-avid tumor, meaning that we do not have a margin anteriorly, it's 0. And on the post-MRI, we found out why that happened. There was a blood vessel draped over this tumor that caused a heat sink, and so we got a 0 margin in this location, and that's, of course, where the tumor recurred. So it turned out that N13 ammonia, while it had a short half-life and was potentially repeatable, it was not practical. Number one, we rarely need to repeat the perfusion PET during a procedure. But number two, you can't ask your cyclotron to drop everything and do another run. And most people don't have a cyclotron. So can we use FDG as the perfusion tracer? And the answer is it works beautifully. So we start off with a pre-procedural dose of 8 millicuries to localize the tumor for targeting. And then at the end of the ablation, we give an additional 3 millicurie perfusion dose of FDG and get our perfusion scan. It's not repeatable, but not really an issue. So we've reported our results on FDG perfusion PET to assess ablation results. And in this example, on a coronal PET CT image, you can see that we placed our microwave ablation probe in the upper half of the tumor. The perfusion PET shows a generous ablation margin around most of the tumor, but inferiorly, where the white arrow is, there's normal liver touching the tumor. So we knew that was an inadequate margin. And we did an overlapping ablation during that procedure and did not have a recurrence on long-term follow-up. And so the point is that our PET or PET-CT assessment is obtained intraprocedurally, and it potentially affects our procedural decisions and hopefully improves our outcomes. In another case, we ablated a tumor under PET-CT guidance. The perfusion PET on the top right shows a very generous margin all the way around this tumor. Notice that on the MRI, bottom left, the tumor is completely obscured within the ablation zone, and we can't really measure the margin. And we did not have a recurrence in this case. This was a palliative cytoreductive ablation in a patient with multiple metastases. This was the dominant one. And here the perfusion PET on the right shows that there is a margin around part of the mass, the white arrow, but in other areas there's a zero margin, such as between the dashed arrows. And of course that did progress. Even if we distort the anatomy considerably with hydrodissection, as in this case where we wanted to push away the projected ablation zone from the anterior abdominal wall, we did our microwave ablation, and then the perfusion PET came at the end of the procedure. And everything we see here reflects the anatomic changes of the procedure because the PET and the CT are obtained contemporaneously. And we have a generous margin in this case. So with perfusion PET, again, we were able to assess the margin in a high percentage of cases, almost all cases, compared to MRI obtained 24 hours later, where we could only fully assess the margin in about 2/3 of cases. And using a 5 millimeter threshold for the minimum margin, perfusion PET was highly predictive of recurrence. And in fact, in only one of 29 tumors where we had a minimum margin greater than 5 millimeters on perfusion PET was the tumor incompletely ablated or did it progress. 75% of the tumors that were incompletely ablated or progressed had a 0 perfusion PET margin. When you look at the Kaplan-Meier plots for reader 1 on top and reader 2 on the bottom with PET on the left and MRI on the right, you can see that both techniques nicely predict ablation outcome using a 5 millimeter margin threshold. But the difference is that PET was more often able to provide the margin assessment than MRI, and it also was intraprocedural. So the advantages of perfusion PET are it's a single image modality and it's obtained intraprocedurally. Because it's a single imaging modality, there's no image misregistration issue to deal with. And by obtaining it during a breath hold, we eliminate the motion effects on our PET image. It gives us a direct ablation margin visualization and assessment. It's a true representation of the anatomy at that time point of the procedure, and it avoids iodinated contrast. Myth number 8, PET-CT assessment of the ablation margin will not work because of the low spatial resolution of PET. Well, we already discussed that that is a problem when you're looking for microscopic or tiny foci of tumor. But what we're trying to assess with PET-CT is the thickness of the margin. And here, for the margin to be adequate, it has to measure at least 5 millimeters in thickness. So if we cannot resolve the margin on PET, it's inadequate by definition. On the other hand, if we can resolve it and it measures more than 5 millimeters, then we have a good indication of an adequate ablation. Myth number 9, ablation-induced inflammation will cause radiotracer uptake in or around the ablation zone during the procedure. Well, this is what it looks like. And we do see inflammation surrounding ablation zones. It's outside the ablation zone, but contiguous with it. But this uptake is predicated on the recruitment of inflammatory cells, and that takes time. And so we can begin to see inflammatory uptake about 24 hours after an ablation, and it can persist for a few months afterwards. But we do not see it during procedures or in the first few hours after a procedure. So it's not an issue when we're trying to assess ablation results intraprocedurally. Myth number 10, retrospective image fusion solves the problems of intraprocedural ablation margin assessment. Well, don't get me wrong, retrospective image fusion can definitely improve our assessment of the ablation margin, and it is helpful, but it has limitations. And the question is, does PET-CT assess some of these limitations? Well, a big surprise we encountered was that PET can depict the tissue contraction caused by RFA or microwave ablation. The way this happened was I was about to do a microwave ablation of a single metastasis from adrenocortical carcinoma to the liver. The tumor turned out to be isometabolic with normal liver. It had the same amount of uptake as background liver, so it was completely invisible on PET. Fortunately, it was visible on CT as a hypodense mass. So we obtained this PET-CT about 90 minutes or more after the FDG injection. So that's already a significant uptake period. We then put in the probe and immediately did our microwave ablation and obtained a post-PET PET-CT scan image. And to my surprise, there was intense uptake around the probe. And I was initially puzzled by this. I was thinking, it's hard to believe that this is uptake attributable to a later time point of the PET scan. In other words, improved tumor to background activity. It was actually a short interval of time between these two scans, and it was pretty intense. And secondly, bleeding into this area didn't seem like a good explanation because microwave cauterizes the tissues, it seals off the volume. And even if there was bleeding into the volume, at this point, at 1 hour or more after FDG injection, there's very little blood pool activity, and it's not going to be greater than background liver. And again, we talked about inflammatory uptake. That couldn't explain it. So it dawned on me that this is tissue contraction being imaged by PET. So what's happening? Well, all of these cells within the tumor and the background liver have FDG within them. And when the tissue contracted around the microwave ablation probe, it pulled those FDG molecules in closer to the probe so that we now had twice as many FDG molecules per voxel as we did just before the microwave ablation. So this was really pseudo uptake caused by tissue contraction. And so that was a pretty intriguing discovery. And so myth number 11, we just addressed. Bleeding into or around the ablation zone does not confound the PET-CT assessment of the ablation zone. But we wanted to further look at this tissue contraction thing, and we were wondering, can we actually see this when we compare our tumors before and after microwave ablation? And so we looked at 36 patients with 41 FDG avid tumors that we microwave ablated. And when we measured them before and after, this is typical of what we saw. This tumor measured 3.6 by 4.2 centimeters before microwave, and it measured 2.9 by 3.9 after. Here's another example. On image B is the pre-microwave PET appearance, and C is post-microwave. You can visually see the contraction of the tumor. It tends to be greater perpendicular to the probe compared to the long axis. And when we measured this manually, the short axis diameters on average decreased 29%, long axis 24%. We wanted a more objective assessment of our ablation volume shrinkage, so we used a tumor segmentation software package, and this showed us that our tumor volume decreased on average 45%. And this is in keeping with what was shown experimentally. So interestingly, there is actually at least one company that has a software package for assessing ablation results that allows you to plug in a correction factor for tissue contraction. I think they suggest 20% or something. But when you look at our results, the average contraction was 45% in volume, but the range, the standard deviation was like from -15 to -75%. That's quite a range. And so if you're going to plug in a correction factor, which one do you use? The point is it's variable, the amount of tissue contraction. It depends on how much water content there is in the tumor and the tissues and so on. Myth number 12, PET-CT misregistration will limit the accuracy of tumor targeting or ablation margin assessments. We initially addressed this by doing breath hold PET-CT with a bellows device where we monitored the level of inspiration. But in truth, we do almost all of our liver ablations under general anesthesia. So we instead started doing breath hold PET-CT under general anesthesia where we stop the ventilator for 35 seconds to 90 seconds, which is very well tolerated. And that gave us excellent co-registration of our tumors on PET-CT images. And also projected ablation zones were very tightly overlapped and similar on showing that we had good registration of our PET and CT data sets. So not only are the PET and CT well registered, but they're acquired contemporaneously, almost simultaneously. And here's a dramatic illustration of why that makes a difference. Here was a large tumor in the left liver that needed to be ablated. It's right next to the stomach, you can see on the coronal image. And so we created an artificial pneumoperitoneum that would allow us to displace the liver from the stomach. We inserted the cryoprobes into the tumor, and then we placed towels on the handles to lift the liver away from the stomach. And you can see we got nice separation on this sagittal image. And as we got to the maximum ice ball, we did a breath hold PET-CT. And despite this radical and anatomical distortion that we're causing during this procedure, both the PET and the CT are obtained almost simultaneously. They're perfectly co-registered, and we can see what our ablation margin is. You simply cannot do this with retrospective image fusion technologies. And of course, we had a great outcome in this case. So what's next? You know, we already use CT fluoroscopy during CT guided procedures, and we actually have CT fluoroscopy installed on our PET-CT scanner in the Amigo. But is it possible to do PET-CT fluoroscopy? Well, CT fluoroscopy is something that allows us we step on a foot pedal, we get a sort of a low dose CT image. It's a partial rotation CT image that we can see almost real time. And it's while we're in the room, and it allows us to work very quickly and precisely to do our procedures. So we approached our manufacturer to see, is there a way we can fuse one of our intraprocedural PET scans with a CT fluoro image? And they really were not able to help us with their current platform. So we reached out to a third-party company that has a device called the IGT Fusion. And they are now working with us, and we're starting to obtain intraprocedural PET-CT fluoroscopy images that look like this. Now, currently, the setup requires a manual push. So from the time I push the pedal and get the CT fluoro image, it's about 25 seconds before I get the fused PET-CT image displayed in the room. But you can see that this is really exciting because now we can get intraprocedural near real-time PET-CT fluoroscopy images that can expedite the procedure and help us do very precise things with PET-CT fluoro. Near real-time in-room PET-CT fluoroscopy. Well, to finish up, you know, we talked about the challenges with image fusion, and how does PET-CT address this? I hope I've convinced you that it addresses a lot of the problems. For one thing, we don't need a retrospective data set. So this helps us account for differences in body organ position that occur during the procedure or changes in organ shape. By doing breath hold PET-CT, we account for respiratory variation. By doing scans at any time point in the procedure, we can account for the distortions of devices and maneuvers like the artificial ascites. Even atelectasis and hemorrhage do not prevent us from getting accurate anatomic depictions. And even the substantial tissue contraction caused by ablation is taken into account by our PET images and PET-CT images. So the promises of PET-CT in interventional oncology, I think, are pretty substantial. Yes, it will be an awkward transition. We still have to work through reimbursement issues and many departments will have to address workflow challenges to make this happen. It clearly requires integrating different domains of expertise, just as we did with PET-CT in the beginning. But as we increasingly move into molecular-based diagnosis and treatment, I think interventional oncologists will be able to capitalize on the image fusion capabilities of contemporaneous PET-CT datasets, the novel approaches to tumor ablation margin assessment that it provides, of course, the use of novel and new radiopharmaceuticals, and then the technology of PET-CT is improving. PET-MR technology is now here. That's going to be used for intervention. And who knows what else we haven't thought of. So this is a partial listing of the many people who have worked with us and collaborated with us on our PET-CT procedures and projects. And I know I've left names off here, but it's a partial listing. And I'm grateful to all of these individuals.